feature in the Olympics opening ceremony was actually quite controversial at home, not with most people, but with the government, because they were in the throes of pushing through a very controversial set of changes to the National Health Service, which actually undermine some of the things that people are most proud of about the National Health Service. One of which is clearly it's publicly provided, publicly funded system, which is a universal healthcare and provides a comprehensive mix of services as well. And people feel that this is under threat. And in many ways, the inclusion of this element in the Olympic ceremony was seen as a kind of one in the eye for the government, because they were paying for this ceremony. And Danny Boyle, the producer, was able to actually get this in as a good socialist and smuggle that in the middle. So that was kind of an interesting one, because it is a great source of pride to British people that we have one of the early healthcare systems that's free at the point of need, funded from general taxation, so it's the most fair and efficient way to actually fund a healthcare system, paid for through general taxation, so you don't have any pre-qualifying period before you're eligible for healthcare. It covers you from the whole of your lifetime, and we're very proud of that. That's something that distinguishes us in particular, I suppose, from the Americans, which I suppose is like in the Canadian situation. Medicare, from 1984, really is the one that's actually singled out Canada. And if we look, there is a lot still that's being contributed by Medicare. In the break from the American system, you can look at the figures, seeing the American healthcare system soaring away in price. They're now spending 18% of GDP on health. The Canadian system has been able to, still has gone up, but it's still there about 11%, significantly lower. You can see those figures diverging in the years from 1984. And you know that your system covers all Canadians for all treatments through hospitals, whereas, of course, the American healthcare system still has tens of millions of people not covered, and even more people underinsured and facing huge bills if they actually need to access healthcare. So I think both countries have a lot to be proud of. And both countries, I think, also have within the ruling governments people who are part of the tiny minority who don't share the consensus, thinking that these reforms are a good idea. Back in England, our Conservative Party in 1948, and bear in mind we now have Conservatives back leading the government again, in 1948, under Winston Churchill, the Conservatives voted time and again in Parliament against the formation of the National Health Service. And there's a whole strand of the Conservative Party right through the whole years in which appeared to be a consensus for the National Health Service, who continue to look for ways of breaking it up and changing it and bringing in private sector. And it now looks as the issue about the renewal of the arrangements for the Medicare come up for debate for next year. It looks like there's a strand of that in your own government, national government, that shares that view in terms of wanting to break up Medicare and maybe reopen your health services back to the Americans that you managed to get away from back in 1984. So I think there's a lot brings us together on these issues. Well, the first thing is to reject the American claim that nobody waits for healthcare in the United States. I mean, you only don't wait for healthcare in the United States if you're rich. Basically, you've got one of these Cadillac insurance plans that will cover you for anything, and if you're actually lucky enough to need treatment in a place where you can actually access that care. But for many Americans, you actually wait just as long as you do in Canada or the UK, or you can't access care at all because you can't afford it. But if you look at the UK system, when the Labour government, which we had from 1997 through to 2010, when that was elected, it was very common for people, because the system was underfunded and under-resourced, or inadequate resources to actually treat the number of people needing care, it was very common for people to wait anything up to 2 years for minor less complicated operations, for elective surgery. And some of those waiting times meant that people were virtually dying on waiting lists waiting for treatment. And this was a big source of scandal. And from 2000, the Labour government decided to change this policy and had a conscious policy of increasing health spending in the UK above inflation, towards the European and OECD average, the richer countries' average. So it started off around 7% of GDP, and by the time they'd finished, the most recent figures is about 9.5% of GDP. Still less than Canada, I say, and still less than the European average and some of the high-spending European countries. But that was enough, because it meant that they could employ more nurses, more doctors, open up some additional beds and frontline services. And that additional capacity, coupled with some tough targets on the managers of these hospitals, meant they were able to get the maximum waiting time down for elective surgery down to 18 weeks. And that's now written into the National Health Service Constitution, which was also a product of the Labour government. By the way, I'm not an advocate here for the Labour government. I'm pointing out things that worked. And they did plenty of other things that didn't work, but this was actually a good thing. And what it showed is the old-fashioned things actually work, which is if you put enough capacity in place, you give people directions as to how to use those services properly, you can deliver those results, and that the private sector doesn't have a monopoly on short waiting times. If you have anything serious wrong with you, obviously emergency treatment happens at once. Cancer treatment, there's a maximum wait time of 2 weeks from referral. So, this is a very significant improvement. The trouble we've got is that the current government, by spending cuts, which it's imposing, restrictions on budgets, is actually starting to undermine this. One of the first things they did was lift all the targets that actually drove these improvements and open up the possibility of longer waiting times. We're now getting operations beginning increasingly to be cancelled for elective treatment because there's no space. The hospitals are filled with emergency cases. So we're now getting some of these same pressures that we had under the Thatcher and John Major governments and when the Conservatives were last in office. And that's a big problem for us. England was one of the first, or UK was one of the first countries to pioneer this, and certainly in relation to hospital building. In relation to the NHS, National Health Service, it goes back to 1992. And it was first proposed as a way of actually, the phrase was privatising the provision of capital for new build and infrastructure of the National Health Service. And the government brought in proposals that any scheme upwards of £5 million, so these were relatively small schemes as well as quite big ones, had to be tested in the marketplace, and the private sector had to be offered the opportunity to bid to put up the money, design, build, finance and operate these new hospitals, and then be paid back over a 35-year period, a long-term lease effectively for the hospital. Only at the end of which would the National Health Service actually retake the ownership of the premises. In some cases, it was 60 years. So these are very long-term agreements. There was a big controversy when these were first argued to be a way of actually doing hospital building cheaper. And this was very quickly shot down because the government can borrow money a lot cheaper than the private sector can. And obviously a key component of this is borrowing these large sums of money. So that was abandoned. Then they started to argue, well, you're going to get innovation. Well, you are getting innovation, but not all these innovations are very good. And some of these buildings have some pretty dodgy design features to them. Innovation, but you also get on time and on budget. Modern public sector procurement can do exactly that anyway, and you don't need to involve the private sector for that. And the other killer argument, which they use all the time, is, oh, well, this means the private sector will take the risk of things going wrong. And this has become the major way in which it looks as if these deals represent value for money, because you take what you claim is a public sector comparative scheme, and then you say this might look cheaper than private finance initiative, which is the phrase we use back home, private finance initiative. This might look cheaper than PFI, but it's only because it doesn't include all this risk that we're going to assume that the private sector will take on, which is in the private sector price. And so they will add on sometimes very large sums of money to make it look as if the public sector scheme has these concealed costs. Very few of these risks are actually real. And when you actually look, and the numbers are almost entirely made up. It is a fictional way of making it look like the public-private sector financing is cheaper. And I've just been in Ontario, and the amounts of money they're adding in for risk there are absolutely ludicrous. I mean, they are now adding in one case, the entire potential cost of building the hospital is put down as potential risk. They're effectively doubling the cost of a public sector comparator. It's absolutely ludicrous. And none of these schemes are being audited. So in England, anyway, as a result of the government buying into this as a way of funding money, the other big thing is it's funded off the balance sheet of the government. So without the government borrowing money, they can appear to be building all these new hospitals, get all the political kudos of opening new hospitals and so on. And all the bills start to land on the hospitals later on as they have to pay it out of their revenue budgets. And so this becomes a long-term liability around the necks of these hospital trusts. We now have £11 billion worth of hospitals are being built under PFI in England. They're set to cost £65 billion to repay, so 6 times the total. These do include some support services, non-clinical services, but even if we take that off, it's still 4 times the headline cost. This is far more expensive than any possible way in which you could finance this under any other form of borrowing. And it also commits you to this long term, as a whole generation ahead, you're committed to paying on this building, regardless of how local health needs might change, local techniques might change. You might want to reprofile services and deliver them a different way. Doesn't matter how little you make you make of this building, you're still committed to paying the full amount of money over the 35 years for it. And this is a real, so they're hog-tied into these really strongly worded, powerfully put together legal documents. And we're now seeing a whole raft of trusts running into major financial problems. We have about 24 of the 100 or so schemes. The hospitals are in serious financial trouble. 6 or 7 of them are right on the edge of bankruptcy. One of them went bankrupt last year with 2 private finance initiative hospitals in this one big hospital trust. It was forced into bankruptcy, and in order to try to raise the money to pay off the back debts and so forth of this, the taxpayers had to come up with an extra £400 million in subsidies and payoffs. And on top of that, a local hospital nearby has actually been closed down to funnel more resources in to help the trust stay afloat. So this is catastrophic for care. And it's prioritising the provision of private profit above the provision of healthcare for ordinary people. So, we can see P3s at work now in Ontario. They have the Brampton Hospital, which was then audited and shown to be a complete catastrophe financially. They've now proceeded, regardless of that, to sign another 4 billion P3 schemes are now underway in Ontario, none of which have been audited, and they're still looking to actually do significantly more. This is in defiance of the evidence. This scheme does not work. It's a very, very, very expensive way of delivering not particularly good hospitals and locking yourself in for a generation to come to a provision of services you may well want to change within a few years down the line. Well, opinion polls show that the public don't trust the private sector to deliver healthcare, and where the public are aware of what is actually being done, they are strongly critical of these proposals. I will say, during the period of the Labour government, when the allocations of money were going up, the waiting times were coming down. It appeared that everything was great up until the point of the banking crash of 2008, which brought it all to a grinding halt. Then lots of people, although they might not approve of bringing these private providers and bits and pieces in, which Labour was doing, they more or less were able to say, well, OK, we don't like that bit, but we're not going to get all that excited about it. It's very hard to build campaigns at that stage. But now we can see it all starting to come unravelled. We can see private sector providers being brought in while the public sector is actively undermined by government policies. We had a major piece of legislation pushed through earlier last year. Was it last year? Yes, it went through last April. Sorry, I've forgotten the timings. Went through last April. It's fully implemented from this April. The Health and Social Care Act, which opens up more and more of the National Health Service to competition, to private providers potentially taking slices of elective care, of community health services, which are the areas that the private sector is interested in, and leaving all the expensive stuff to the public sector budget to pick up. Then under those conditions, people are starting to wake up to the fact that this is a real threat. And we are getting some very angry campaigns, especially where hospitals are threatened with cuts and closures, local services are threatened. We are getting tens of thousands of people turning out to protest. We are getting very big petitions, very big lobbies. And I think this is all set to continue because the financial squeeze we've had since 2010, when the funding increases stopped, is set to tighten for the foreseeable future. There's no end in sight. Goes on after the next election into the 2017, 2020, who knows when. So it's not like you can say grit your teeth and put up with this. It's all going to be better in a few years. There's no light at the end of this tunnel apart from maybe a train coming the other way, driven by the private sector. Well, in terms of the public-private partnership deals, P3 deals, I mean, the British government has for the last 2 or 3 years recognised it had a problem here. Teams of accountants have been brought in, so-called hit squads going into the trusts which are struggling. We've had an attempt to set up a bailout fund of £1.5 billion for 10 of these trusts in the greatest trouble, but which had so many strings attached that hardly any of the trusts have been able to access any of this money and make use of it. So bit by bit, I think more and more people are realising that this is a policy that doesn't deliver, but I don't think it can be reformed. I think it is fundamentally flawed. And in fact, the chief executive of the regulator of hospitals, Monitor, which is he's actually a former director of McKinsey's, the private sector management consultants. David Bennett. He has actually argued that since these P3 schemes, once they're completed, once the hospitals are up and running, the schemes are quite often traded now on the stock market. He's saying, well, maybe in some cases the best thing to do is just buy them back, at market prices, because the market price might actually possibly go down a bit, but buy them back rather than continue to pay the contracts out. So, if he's saying it, I think you have to recognise the government has and we have a bit of a problem dealing with them. And what I generally think that Canada should learn is that, these schemes have been rushed into. The British government is leading the world in some of these reforms, so-called reforms, without any evidence that they're going to work, disregarding the evidence where it doesn't work. And I do think that Canadians who have got as much to lose by the loss of erosion of Medicare as we have from the NHS really need to learn from this example. It's dumb enough to make a poor policy once, but to actually then replicate it when all the evidence is it doesn't work, and to replicate it in conditions where nobody's pressing you to do so is just absolutely absurd. And really it is the case that public sector funding, public sector provision is the most efficient and effective way to deliver health care. It's the most equitable. It gives you the most scope to plan and allocate resources according to need. If you start to break that up, you replace it with something that's not as good. And that, I think people just need to bear that in mind and just, don't do it here. Just don't do it here.